I'm Meryl Greenblatt. I would like to welcome all of you to this evening's event, Health 2.0, New York City, New Business Models in Healthcare Opportunities and Challenges. It's a pleasure to have you all here. We have a wonderful venue given to us by Smart Design, who will talk to you in a few minutes. Now, how many of you folks are here for your first New York 2.0 healthcare meetup? Oh, we got a pretty good mix of people. How many, let's see, so how many of you have been here before? Wonderful. Were any of you at the Affordable Care Act event that we had back in April? Okay, wonderful. Okay, for those of you who are not familiar with our meetup group, we're about 3,800 members at this point. We're still growing, getting close to 4,000. We're basically a universe of providers, payers, designers, engineers, anyone, business people, investors, venture capitalists. What we do is we bring the whole of the business community in healthcare together, and we give you the opportunity to collaborate, to talk, to make connections, because we feel that the best way to accomplish something and to succeed in healthcare is to work with people you might not usually think of working with. And it's another way to find out who your stakeholders are and find out what their needs are. Okay, just to let you know, this meetup is also going through TweetUp. Our hashtag is H2NYC, so if you tweet your questions, they will appear on the screen later. This is going to be a very interactive program. When I'm done, Michelle, our key presenter, will talk for a few minutes, and she will introduce the rest of our panelists. But actually, what I'd like to do first, I just want to say a big hello to Alex Fair. Most of you who are here know Alex. Alex is the organizer for this meetup group. And he said basically after 50 meetups, he decided to take the summer off. So he sends his regards, and we thank you all for being here. And I believe he's home watching, so if everyone just says, hello, Alex.
Hello, Alex.
Okay, we're good. Okay.
Wish you were here.
Wish you were here. Okay. Let's see, some logistics. Okay, the bathrooms. If you go out back to the registration area and make a right, there are bathrooms over there. You don't need a code or a key or anything. Oh, let's see what else. Let me thank the volunteers. We have a great community, and what's really important is the people who do the work here. It's all volunteer. We've got Anthony Manson is helping me out this evening, Mimi Rosenfeld. We've got Andrea Miller somewhere. Okay. I don't know if Amrita Herkel has come in yet. Also, Jeff Borenstein from MedStarter. If you just want to point your hand up and wave hello. MedStar is one of our sponsors also. And Jenna can't be here this evening. Also, Mike Schwartz is our cameraman. Thank you very much, Mike. So Smart Design was very kind to give us this venue. It's a great place. They're a great company. And Tom Isaacson has helped provide the food. These cute little buttons we're all wearing. And what I'd like to do now is actually bring up Jamie Nicholson, Smart Design's design strategist, to say a couple of words before we get started.
Thanks. So I should probably point out I'm not the only design strategist at Smart. There are other ones as well. But first of all, thanks to you guys for all coming out. I mean, it's pretty horrific out there. So, took a lot of motivation to get here. And I guess it speaks to the quality of these events and also the quality of the conversation that we're going to have tonight. So thanks for coming. And then also just a big thanks to the Health 2.0 meetup team. These things take a lot of time and sort of effort to organize, and it's really great to see sort of you guys building such a great and engaged community in the city, and also just to organize these events and let us all be part of these really fascinating and important conversations. So thank you. So I'll just tell you a little bit about Smart Design, and then I'll basically hand it back over to Meryl and then the panel. So we are a global design innovation consultancy. We have 3 offices, one here in New York, one in San Francisco, and also just recently opened up one in London. We tackle a very wide range of problems, and we work kind of for a very broad range of clients too. The disciplines we have here are sort of service and business design, insights and strategy, interaction design, industrial design, design engineering, and brand communication. So we tackle a lot of things. And over the number of years, we worked in a lot of healthcare projects and sort of a lot of different spaces in the healthcare sector. So we're really always sort of excited to hear the conversation and be part of it. And so when we kind of tackle healthcare problems, we always tackle them with this one core belief, that is to design with meaning. And we're really interested in this conversation tonight because, if you think about kind of the opportunities to design with meaning in the healthcare space, there's tons. And even kind of small improvements can have a real meaningful impact on people's lives. So to kind of come up with these meaningful solutions for people, we really go out and we try and understand their needs and their desires, the kind of conversation they're having with people, their relationships, and just really understand what's going on and try and come up with solutions that really kind of meet these needs. But you can't have a meaningful solution if it doesn't exist. So it's really also very important that you kind of bring meaning to business. So in the context of healthcare, we believe it's really important that you understand the ecosystem, the stakeholders, what the needs and what the needs are there, the kind of regulatory environment and all that complexity. And it's only really when you bring those two things together you can design something with meaning and deliver something with meaning. So, this is a really relevant conversation to us, and we're really kind of excited to be able to host it and really looking forward to just learning more about how we can all deliver meaning in this space. So thank you.
Thank you very much. Okay, let's get started. One more logistic. At the end of the evening, we will have more time for networking. I just want to reiterate, networking is a big part of this event. It's meant to be interactive. We'll be asking the audience questions. We'll be looking to hear other questions from you. Because it's really, again, it's a group effort, it's a collaborative effort, and we could all learn from each other. So without further ado, I'd like to introduce Michelle Zimmerman. Michelle, if you had attended the Affordable Care Act event we had back in April, Michelle represented the new payer perspective on this. Michelle is Chief Innovation Officer at Alpha Healthcare. It's a company, its newly launched healthcare plan. It caters to the managed long-term groups, Medicare, and the dual eligible contingency. Michelle comes from Aetna originally, where she had been with Healthogen Division, and she was a founding member of its business innovations team. Prior to that, she's had experience, she was with the Boston Consulting Group, and before that she practiced corporate law at Paul Weiss, Rifkin, Wharton, and Garrison. She has a JD, MBA, and an honors bachelor degree from University of Toronto. She's a member of the New York State Bar. So everyone, please give a warm welcome to Michelle.
Meryl, thanks so much. Thanks, everyone, for being here. Big shout out to Alex and to the Health 2.0 team and to our awesome panelists who you're going to meet very shortly. Hopefully it's a very helpful and informative event. So, the title of today's talk or today's session is really around business models. But I don't think you can really appreciate business models in healthcare without really understanding what I call the misaligned multi-stakeholder challenge and the opportunity for innovation. Yeah, awesome. Okay. So I know this slide is really, really, really busy, but what I wanted to do here was actually introduce the cast of characters. So when you think about healthcare, there's a lot of stakeholders. So I'm going to walk you through them from left to right, and we're thinking about these stakeholders before the Affordable Care Act, before some of the disrupted trends that we've been experiencing in the last few years. So you had the consumer, most of us in the room here, we had pretty good benefits if you were employed at a good company. You really didn't bear any of the cost. You went to the doctor when you wanted to go to the doctor, and you didn't really think too much about your long-term health. This notion of health and wellness wasn't as prominent as it is today. And then you think about risk bearers. And a lot of people get risk bearers and plan administrators a little bit confused. So a risk bearer is anyone who is actually taking risk on a population. So Bank of America, for example, would be a risk bearer. So they are carrying the risk on all of their employees. But they might use Aetna or Humana to help them administer that health insurance. So those risk bearers are liable for the medical costs, but they're managing the risk for a period of time. So people change jobs all the time. Maybe you're only there for 2 years or 3 years. And so they're really focused on reactive care. And they really have limited influence at the point of care. You're getting the care at the doctor's site. The Bank of America of the world, the Costco's, have no idea what's going on when you go visit the doctor, and yet they're paying for it all. When you think about the plan administrators, the Aetnas, the Humanas of the world, they're really pricing insurance. They're selling you a product, they're giving you a premium price, and they're going to make a margin off of that product. And they build a network. They build a network of providers. And only a few years ago, if there's providers in the room, they may know this, insurance companies were going to providers and negotiating rates. They weren't negotiating on outcomes. They weren't negotiating on qualities. They were negotiating purely for rates, which is a good segue into our providers. So they obviously provide the care, but they're also used to be reimbursed for a fee-for-service basis. It's a very transactional type of process. And so what that means is there may be incentives to treat without delving deeper into other less sort of intense processes or alternative medicines, and they're not really accountable for quality and outcomes. And then vendors. So there's been a lot of press around the cost of oncology drugs and the cost of drugs generally. Well, you know, in the old world, pharmaceutical companies and other vendors could command a price premium, and they made money from that. So, you know, the bottom line here is healthcare stakeholders with misaligned incentives are creating distortions as they look to maximize their own profits. But this is all changing, and you know, none of this should be new to probably anyone in the room. There is a lot going on. So there's underlying trends. We're aging. We fundamentally can't afford our healthcare system anymore in its current state. There's legislative change. You have the Accountable Care Act. You have federal and state laws that are creating new products like dual eligibles, so marrying CMS or Medicare with Medicaid to really help what we call the most highly need, the individuals with the most high need who are the sickest of the sick. There's new expectations. If you're paying out of pocket, you want to know how much it's going to cost you. You want to see that doctor on demand. You don't want to wait 3 days. You want to go to that urgent care center, which we'll hear a little bit more about. Technological disruption. We have the capabilities, we have the tools. I'm sure you all might have ZocDoc on your iPhone or on your Android or whatever when you're looking to make an appointment. We're going to hear from Epion Health that really provides an opportunity for providers to digitalize patient check-in. We have the capabilities. And there's maverick players. There's new entrants. There's old entrants like the Walgreens of the world or the Costcos of the world who want to play a bigger role in healthcare. They want you to go there and fill their prescription and see the doctors. So there's a lot going on. And to me, this is all a good thing, because if we go back to our cast of characters, the world for them has changed. So the consumer, who wasn't really paying, is now shouldering the risk. And there's a huge movement around wanting and needing to be healthy and well. How many people in the room here are wearing some sort of Fitbit or Nike Fuel Band? Can you put up your hands? No, seriously? No. Who lost it? Who had one and lost it? Yeah, that's me. I've lost 2, yeah. But in any case, so what that means is we're now sensitive to cost. We really want to make informed decision. We want information. And we're now more motivated to invest in our own health, especially if we'll be paid by our employer through some of the incentive dollars. And going back to sort of the risk bearers and plan administrators, they have capped profitability. The ACA fundamentally limits the amount of money they can pay or they can make from pricing risk. And so there's really a need now to invest in preventative care, to focus on engagement. When insurance companies are going to the provider world and contracting, they're now contracting on outcomes. I'm sure everyone in the room is probably familiar with value-based reimbursement. It's now a partnership model to help insurance companies and providers work together to help people stay healthy. And so if a provider now is carrying the risk, they really need data to understand their population. They need a team to manage their patients outside of the hospital. Providers see patients on average 3 times a year. That's a lot of time individuals are not with the provider. And vendors, so going back to those pharmaceutical companies, EHRs and other vendors, they're really being held accountable for the value they're delivering. So there's a lot of movement toward pharmacovigilance, looking at drugs once they're in the marketplace, pricing new drugs relative to the ones existing to see the incremental value. And you know, I love that we're at a design firm, because part of the way a lot of vendors are doing this is really with customer-centric design, really understanding the needs of their users, their intermediaries, and solving for the real problems. Okay. And so if we look at what we just talked about, I listed off a whole bunch of new needs. And so this is a great opportunity for entrepreneurs to step up and solution and solve these needs. So again, for illustrative purposes, so the consumer, so they need to understand claims. Simply is a product, a company out in San Francisco who's kind of like the mint.com for healthcare, a place for you to aggregate all your financial information and pay it. Select the right provider. Castlight Health, which just IPO'd for over $100 million, is really trying to help build price transparency and provider selection to enable consumers like us to make the right decisions. And then obviously, you know, the Fitbits and Nike Fuel Bands, a way for us to really understand how our own behavior is affecting our health. And going back to these risk barriers, if I need to build an efficient network and help my providers in that network work together, primary care physicians and specialists, I might want to use Pareto, which is a new referral application to help networks work together. If I'm providing my employees with money to go buy their own insurance, maybe I want a private exchange like Bright Horizons with Liaison to help them select the right plan for them. And providers. So providers now, hospitals, they're becoming businesses. They need to recruit members. MedSeek is a digital advertising company that's helping providers identify patients who need their services. Cypher Health. Cypher Health is really helping providers. It's one of those 30-day readmission tools. Hospitals are now on the hook for managing patients not only when they're in the facility, but what happens after they leave. These are great opportunities for entrepreneurs to come in and solve very, very specific problems for key stakeholders. But it's really not easy. So, you know, Meryl mentioned, I spent a couple years with a team at Aetna where we were really focused on building new healthcare technology companies. And I learned a lot of lessons. A lot of lessons from a lot of mistakes. But I thought it might be worthwhile before we delve sort of into the panel and speak from the real entrepreneurs here, you know, some, I guess, rules of the road or things that I'd love to impart. So these understanding the needs of these stakeholders is really, really, really important. If you take a wellness company like ShapeUp, okay? ShapeUp's end user is someone like us, a customer, a consumer. But we don't really pay for it. They're selling it to a big company like Bank of America or Costco. But maybe they're not even selling it directly. They may have to sell it through a broker who's advising Bank of America or Costco. For them to be successful, they need to understand that entire interplay to be able to get everybody on board with that purchase decision. Know where your solution fits. So I spoke a little bit about this provider referral application. So a primary care physician wants to make a referral to a specialist. How do they do it? Maybe a technology can help. But for them to be successful, they need to know what the provider's doing with their electronic health record. Are they willing to go to another application? Is it really them who's doing it or the practice manager? It's complicated. Demonstrate value. So you really need to be able to show a return on investment. There are a lot of new technologies, a lot of new tools. Companies have a lot of pressure to cut costs, insurance companies, providers. So in order for you to win and to sell, you need to be able to demonstrate a return on investment. So if you're a care management company and you want to sell to a hospital, and you want to promise that we're going to manage your cardiovascular patients after their discharge, you want to be able to demonstrate reduced readmissions. And they need to be able to quantify that impact on their bottom line. This one I love because, again, we're back in this design studio. Design in partnership. So there's one thing about, you know, seeing a problem and looking at it academically, but there's something else about actually being with your customer. Putting design mock-ups in front of your customer, getting their reactions, and taking that information and refining it. You know, that's a process that at Aetna we developed from the ground up, which is really when we were building companies, we would go out for 3 or 4 days with our customers, with our end users, with experts, with design and prototype markups to get their input, and that really helped us move forward. Beware of changing legislation. There are some things that are just outside of our control. The FDA, are you going to regulate? Are you not going to regulate? You know, Google going in to try and get, or Apple going in to try and get answers for us. I can tell you in the company I work at today, which is a new insurance company, we're in the running for this dual eligible program in New York City called FIDA, and we learned early today that it's going to be delayed. So this happens to everyone, and you just need to follow it. And then I guess finally, leverage accelerators and incubators. There is a lot of complexity, and there's no need to go it alone. There are tons in New York. We have a great community. Look at everyone in the room here. Everyone is somebody you can talk to. Everyone has a unique perspective. But between Blueprint Health and Startup Health, and you've got Yossi here from the New York Digital Health Accelerator, there's lots of opportunity to get help. So you should seek it. So that's, I guess, yeah.
I'm going to take that microphone.
Okay.
We won't have audience questions.
Okay, so let's use this one. Does it work? Okay.
Yep.
So basically that's, I think unless anyone has any questions right now, maybe it makes sense to just delve right into the panel and meet some of our entrepreneurs. So I'm going to ask each of you to introduce yourself and share a little bit about the company you work for and your role. Joe, we'll start with you.
Okay. My name is Joe Blewett, and I'm the CEO of Epion Health. And Epion Health is in the business of engaging patients at the point of care, beginning with the patient check-in or patient registration process. So we basically replace the clipboards and paper forms with an iPad solution. And once the patient's completed the check-in process, then we deliver a patient engagement solution around patient education and other deliverables and direct-to-consumer information. And we're kind of a startup organization, but we've been at it for a few years. But we've really just commercialized our product this year. And glad to be here. Thank you. And we're hiring, by the way. So if anybody's got some skills that you might think that might play to our company, be sure to talk to us. There's a bunch of us here tonight. Thank you.
Can you just give one of the accounts you've opened in the tri-state area or East Coast?
Yeah, I'm sure. So I think our biggest thing just to say tonight is that we integrated with Athena Health last year. We partner with them, and we are now basically selling directly to the Athena Health physician population and practices. There's 52,000 of them or so we're going to be busy with that for a little while.
Hello, everyone. My name is Calvin Huang, and I am part of CityMD. CityMD is, we started out as New York's urgent care. We are an urgent care company, and we're 3 years old. We have 30 locations today, and we have a very aggressive expansion plan. What I do at CityMD, I'm not sure if I'm the right person to sit here representing CityMD to this group, because I think this group is very smart. I am in charge of brand, marketing, and HR at CityMD. And my title is Chief Experience Officer, and that's one of the things that's very unique about CityMD is that we are passionate about every patient encounter. So essentially, I control the mind of before they come in, and once they come in, what they experience at the site, from the check-in all the way through the doctor to the discharge. And we have actually more stuff that goes on even after your discharge. So I can talk about that a little bit more later.
Hi, my name is AJ. I am one of the co-founders of Traveris, and I lead the product team. What is Traveris? We provide SaaS solutions for large payers, specifically health insurance companies, PBMs, consulting companies as well, and government entities. We have 3 key solutions. We provide validation, we provide procurement, and we provide reporting packages. A lot of this was born from what I would say payer confusion in the market. What I mean by payer confusion, health insurance companies. In fact, the question I got earlier today was, how did I end up in healthcare? I'm actually an interloper. I come from finance and from software development. What happened is I had dinner with a health insurance CEO, and he was vetting one of the ideas that I was having of possibly getting involved with healthcare. This is about 4 years ago. And what was interesting is he thought my idea was okay, but he kept going on and on about a bill he would pay every single week, $30 million he'd write a check for, and he never knew what was in it. And I'm like, this guy's just rather a really bad manager. He's had one too many drinks, or, we'll find out if this is true. It turns out, after a little bit of research, every single payer in the United States, including the federal government, blindly pays their bill every week or 2 weeks. They just wire the money and no one knows what the heck's going on in these pharmacy transactions. So we built a platform to help unravel this mystery, which then led to procurement, which then led to reporting packages. So what we do is provide efficiency in the pharmacy benefit kind of food chain, and we've been at it for 4 years now.
Works for me. Okay. Hi, my name is Adam Griff. I'm a co-founder with SarahCare, and SarahCare is a comprehensive aging in place solution. So what we found is that families oftentimes send their loved ones into institutional care before they're really ready or that's appropriate because they're simply overwhelmed with the complexity of managing care. And so we provide adult day health centers, which are hubs for all the services for their loved ones, and geriatric care management and concierge services so the caregiver gets all the support they need, everything from pharmaceutical consultations to help with medication management to dry cleaners dropping their dry cleaning off at our center so they can pick them up with mom.
So question for the panelists here. We talked a lot about stakeholders. There's a lot of stakeholders with a lot of needs. Can you share with the group here a little bit about which stakeholders you think about, how you think about them, and what role they play for you in your business model?
So this is, if I only get to respond to one question tonight, this is the one that I was hoping to be asked. This was a really big challenge for us because, as you can imagine, we have access to these patients with an interactive solution. At the point of care, we know who the patient is, what their background is, what their medical history is, their demographics, et cetera. So there's a lot of stakeholders who are interested in being somewhere in that interaction. And we really kind of had to figure out how to handle that and who to go after first. In terms of what ended up being defined to me as our primary fiduciary stakeholder or client. And we actually went down for almost 2 years, a year and a half or so. I think we actually went down the wrong pathway, where we selected a stakeholder who we thought was the best stakeholder to kind of align ourselves with. And we've literally walked away completely from that stakeholder. And just I'll put it out there, it was originally going to be the pharmaceutical medical device companies and giving them access to patients. And I thought that's the world I came from, and there's just so much money there, and they want this access. And we actually found out that was, we concluded that was just not the right pathway. But in the end, there's 3 or 4 stakeholders. We could be, it could be the stakeholder, like I said, as pharma or advertising. It could be the doctor, the provider, the consumer potentially. You could focus on the consumer. There's other stakeholders out there like payers, et cetera, that are potential stakeholders. So in the end, we just had to pick one. And we ended up picking the provider. So our primary stakeholder is the provider. So we make all of our decisions now around what's best for the provider as our first decision point. And then other stakeholders can come into that decision process afterwards. But it really was a huge, huge process. And it involved a lot of discussions and actually piloting programs, et cetera. But if anybody's in a startup world or is just starting a new product or a product line, I suggest that you work extremely hard on identifying that stakeholder and making sure that that your business model is aligned to the proper stakeholders. And you might not figure it out until you go out to the field a little bit, but try to do that as early as possible, save money, save time, et cetera.
Well, so let me just ask a follow-up question here. So I didn't want to call it out, but I noted when AJ and Adam introduced their business, they also introduced the problem they were solving. And Joe, I don't think you and Calvin did that. So I wonder if you could talk about the problem you were solving when you were looking at the pharma clients as your primary buyer, and now the problem you're solving here. but it sounds like it may have been with a similar type of product.
The product actually changed a little bit also, and I'm going to be aware of the fact that I'm not the only panel member here tonight. But in the beginning, the product was more about just patient engagement. Later on, we brought in the digital check-in. So the patient engagement appeared, the pharmaceutical medical device world, advertisers. That was a really good space because you're just engaging patient with content and education, and you can throw in a little marketing in the mix. So, but again, we kind of walked away
But
from that platform.
what problem were you
So
solving?
the problem was getting them access to the patients. So they have these products, and they spend literally hundreds of millions and billions of dollars a year on television advertising and other broad-based advertising, trying to get to the patient population that is actually the targeted audience. So if you know who, you're in a oncologist office, and you know that somebody has breast cancer or whatever it is, you now can target messaging to that patient. So we had a platform to basically drive and that access point for the pharma and other potential interested stakeholders. But again, we just found that now our problem is now helping providers to solve inefficiencies in their workflow, to help them to reduce the costs, increase their revenues, help collect payments. It's just a little bit of it's a very, very clearly defined and unambiguous pathway at this point. And there's other stakeholders that still play in our space, but they are now the primary stakeholder, and we're in their space anyhow. So that's where it kind of came. We're in they're in their house, so to speak. So that's really who we decided needed to be our primary stakeholder.
I have Dave Stadler there from CityMD. He's a brilliant guy. Everyone at CityMD knows that I have an attention span of 5 minutes. So what was the question again?
Who are, when you think about your business, who are the stakeholders that you're most concerned with, you interact with? You're the experience designer.
So a lot of these businesses that are very successful, I think we are fairly successful today, starts out with a very obvious problem and a solution. So it was a bunch of doctors that worked in ER that were working very hard and were seeing 70 and 80% of the patients that were coming in that did not need to be there. So they spoke to the hospital group, I won't say which one, and they said, why don't you let us open up something called urgent care, and we will take care of the patients. And the really sick patients that come in, we'll send to you guys, so we both benefit. So we will alleviate some of the patient flow, and we will send you the patients that you will make money out of. So that's how it started. And it was a very simple problem of just providing medical care to people that didn't have to go to ER. Once they started doing this, they realized there was a problem of access, that most people did not go to doctors' offices or ERs because it was just very difficult. The whole experience itself was miserable. So rather than going to see a doctor, they would sit in bed, lie in bed, and just get better and just bear with that. So essentially, we started out with access. So we're an access provider, and that's and our stakeholders. As the business grew, we're 3 years old, we are learning more and more that there are a lot of stakeholders. And the three constituents that we always talk about are the payers. We have to have a good relationship with them, and the government agencies that can change the rule overnight. But our focus has always been patients, and we believe that the payers and the government have a lot of power now, and they are very important to us. But the money follows the patients, and I think that's how healthcare should be. If you take care of the patients, I think everything else needs to revolve around the business itself. The industry itself needs to revolve around patients.
Hey, one of the things I always talk about is the more disruptive your company is, the more valuable your company becomes. And in the course of that action, you develop allies and enemies very quickly in the healthcare industry. It's one of the things that I discovered early on. So you talk about who are these shareholders. Well, when we started our business, perhaps we were naive. I thought the health insurance companies, PBMs, are going to love us. We could help them check this stuff to make sure their people are paying the right amount of money and it's efficient and they won't get in trouble. And they were like, I want to break your legs. And I was like, that doesn't sound right. Our core buyer wants to kill us. So we wanted to go back to the start and be like, why is that? And cash flow. No one wanted to have their cash flow interrupted, because if you think about it, healthcare is pretty interesting. My company's 60, 90-day, 120-day receivables. These guys get paid in 24 to 48 hours. Suddenly there's this company out there who's like, well, if you're a payer, we're going to check the bill, and you're only going to pay the claims that are correct. I mean, it sounds right. We've sent invoices to people. I'm sure everyone in this room at one point has sent an invoice, and if it's incorrect, what happens? They send it back and say, fix it. So we thought it was a pretty logical process, but these are very powerful companies. So their initial reaction is shut you down, and the cease and desist letters start, and we start blowing money on attorneys, but we knew we were right. And I'm going to say thank you to our investors, because they knew that we wore the white hats. They knew that we were solving a very important problem, and without them, we wouldn't have done it. I'll be perfectly frank. There are some people out there, and bless them for being able to just bootstrap it and get it done and solve their problems. But for us, it was a really big problem, and we needed some significant funding to back us to get through this process. We also had to pivot, which was, well, they're fighting us on the data rights. They're fighting us on the ability to audit. So in order to get there, we had to pivot and be like, I need to be in control of the contracting process. In order to be in control of the contracting process, we had to be in charge of procurement. So we had built this wonderful claim processing engine. In fact, it's the only claim processing engine that's not owned by a PBM or a health insurance company. That's how we're able to scale these. I mean, I think this year we'll probably go through 400 million prescription claims. So more than, I would say, we're going to be greater than 1 in 10 prescriptions flow through one of our systems. And it's a tribute to a company that's been around for 4 years. But when we moved to procurement, we suddenly saw all of these PBMs and health insurance companies start smiling at us and being like, oh, that lawsuit was just frivolous. You know, that was a mistake. That guy's gone. We're going to move forward with you, because suddenly we're in charge of, hey, this $100 million plan is trying to select a health insurance company or a PBM. I want to make sure you're the right partner. And this isn't a slight against the health insurance companies, PBM. So there's wonderful partners out there, and we continue to grow those relationships, because once they understood what we were doing benefited them and their own business models, it led to other opportunities. So our reporting platforms that are used by PBMs as well as health insurance companies, our repricing platform, some of them use themselves because we're able to do it so rapidly. It led to what I think is a very rewarding relationship. So if I can let anyone know one thing: when you create an idea and you want to be an entrepreneur, the more disruptive you become, you're going to have some enemies. But if you stay the course and you're really addressing an inefficiency or a significant problem, you can turn them around.
So I'm at the end here, so you're probably tired of this question by now. I'll try to keep my answer short. But so long-term care is interesting, a little bit different, because where in healthcare the costs were originally hidden from them, and now they become revealed to them and they bear the costs. Within long-term care, what's happened is, if you were in assisted living, you were a consumer, or what we do, adult day health centers, you were a consumer-facing company, and your families bared the cost, and they were highly recognizant of what was going on. So that we were already where kind of healthcare is moving right now. Now, what's changed for us now is actually the complexity of the stakeholders we deal with in terms of hospital readmissions. And so we were very strategic about how we handled that issue in terms of working with hospitals, because they were a good referral source for us. So even though we offer a comprehensive service and we do all manners of things, one of the things we don't do is we don't provide rehab ourselves, right? Hospital companies have their own rehab companies. And so we work with the hospitals and we work with the services that they provide, like rehab, so that we can help them reduce their hospital readmissions rate while now not competing with core services of theirs. So I think when you look at this kind of landscape of stakeholders, you kind of have to decide, who you're working with and who you're really competing with, and it's not such an easy and clear-cut issue.
I'll tell you what, why don't we take some audience questions at this point? Anthony has the mic. How about someone from the audience? What's a question for the panel, or what are some of your issues? I see a hand over here. Can we? Oh, okay. Oh. 1 second. She's going. All right. Start back here, please. Sorry.
My question's for Traveris, if I got that name right. So questions about finding the problem to solve and then finding the right stakeholder. And yours was clearly the journey that a lot of healthcare startups go through. So my question is, what was the time frame that it took you from your idea to the point where you figured out you had a stakeholder whose problem you could solve with recurring revenue?
Great question. In B2B, I think revenue rules the day with my board. So you got to make sure you're solving a problem and someone wants to pay for it. So really good question. It took us a year to develop our software, kind of getting out of alpha. So during that time, everything was rainbows and happiness, and we were patting ourselves on the back, and we thought it was wonderful. Then you start moving to the sales side, and that was where the difficulty began. And I hate to say, sometimes you must be willing to destroy what you create. And that was a really tough point for us. You sit around a kitchen table, and at the time maybe there was like 10 of us, and you're like, this isn't the product that's going to make us or our board happy, so we need to pivot. But the technology stayed at the core of everything we did. So after we launched, I would say it took us 6 months to figure out something was wrong. And thankfully, when you're small and agile, you can make that pivot pretty quickly if you're dedicated. And within 3 months, we kind of put out our second product, which is known as the TrueBid platform. And that's what kind of saved us, I'm going to say. So I would say all in all, it was 6 months to kind of look into the abyss and then to get that understanding or the answer is going to be, and then 3 months to make the pivot. And then thankfully, we're able to salvage the year.
Okay, thank you. We have a question up front.
Thank you. I want to follow up on a point that you made, AJ, but I want to get everyone's thought on the influence of information, the data, the control of the data and where it's stored, and how that provides as, how that's positioned as a leverage in the conversations you have with your stakeholders, and how that specifically influences your business models, because to a good extent it does. And I want to get everyone's thought on that.
Real quick, we're on the side of the payer, so we always take the position the payer pays, so it's their data, often representing the patients. So we're a cloud-based SaaS platform, so early on in that conversation, it was difficult. I'm going to give a plug to Amazon, because during some of those very difficult conversations, they brought the leadership from Amazon to some of our meetings with us, and we're able to get through working with very large companies who had up to this point been like, PII in the cloud does not mix. But when we're able to say, look, we use the same government cloud as these government agencies, and we follow, if not more stringent security protocols than maybe even your own infrastructure, it was very helpful. So data is everything for us. It's our business. There's always going to be some conflict around it, but if you're on the side of the payer, it's pretty clear cut. I do want to make a second point, which, because I spent this past weekend revisiting HIPAA and the Privacy Act. By the way, if anyone's actually read the Privacy Act, the preamble on that is fabulous. Whoever wrote that actually did a really good job. It was one of the few government documents that's actually interesting for the first 10 or so pages. But What I did want to point out was we were doing it because one of our payers had a question about patient rights and patient data. And HIPAA's usually pretty clear cut under anonymized, de-identified use of data for them, the payers. But it's kind of a modern battleground. Everyone is going to face a different challenge in how to extract that data. For us, it was fairly easy because our clients have the right to it.
I mean, I think the overall challenge with the data for us, we're more involved on the care coordination side. And so in order to take proper care of our clients, our participants, we want information from the hospitals. We want information from the physicians. And there's not really any collaboration there at the moment because everyone's kind of afraid of someone outside their organization looking over their shoulder, right? So everything is the conduit is through the family, which is not always kind of the best conduit, especially when you're dealing with something like we do with long-term care where, the caregiver is under tremendous stress because maybe their father just had a terrible stroke. So, and I don't have an answer to that question, but that issue of how are you going to collaborate and people feel like they're not going to be judged and punished for that collaboration is a question that still needs to be answered.
To echo his point, data is everything to us as well. And I think it's, today, we always ask, our board and our executive team always ask, do we deserve to exist? Does urgent care deserve to exist over a long time? We are solving a problem today. People love us. We know that. But over a long run, are we a solution in healthcare? And how are we coordinating care so that patients not only come to us and get better short-term, but long-term as well? So one of the exciting things using data, because we have a ton of data, we see a lot of patients, is we are launching a new urgent care called HEAL in Jackson Heights, Queens, in October 1. It's a different brand. What we are doing is we're piloting a urgent care towards managed Medicaid patients. Right now, CityMD does not take managed Medicaid, but we are taking 30% of our population is on managed Medicaid. So we want to gather data and we want to coordinate care with people that can provide long-term care to the population that needs it. So so data is very important, and that's how we leverage in speaking with our payers about how valuable we are and why we need to exist over a long run.
Okay, we have a question back here.
Question for Calvin. Calvin, what technology advances do you see in the next 2 or 3 years which will have a positive impact on the patient experience?
I think I'm going to talk to this guy, this guy, and this guy. We are all about making everything easier for the patient. As far as I think I mentioned it. When we talk about our competition, a lot of people think our competition is ER. It's not. It's not the primary care physicians. It is the patient's bed. That's our competition. People don't want to get out of bed because it's so hard. It's not like going, imagine if you had to get coffee and you had to go pick coffee, roast it, grind it. No one's going to get coffee if it's that difficult. And that's how it is with seeing a doctor. It's so difficult. So we're all about making everything easier for the patients. So there's a lot of technology that we are looking into, and I'll talk to these guys as well. But we've been very busy, but we are investing in a lot of resources to the next things to make things easier. Registration is one.
I'm glad I came tonight. That's good. Actually, the question was for Calvin, so I don't think I'm going to answer that question. It's been answered.
I have a question for Joe. It goes back to the first thing you explained, that the primary stakeholder was pharmaceutical companies, and what decision it took, or what actually happened for you to move away from that, and in addition to that, also change your technology to a new stakeholder? And how long did that take you to get there?
Yeah, like I said, it took us a long time, about a year and a half. And actually, one of the reasons was because one of the pharma companies funded a large percentage of our startup costs and funded a pilot, and we got great results out of it. And it was really hard to decide that even though we had good results and a very interested party that appeared to be a long-term, revenue stream, we just said, you know what, the doctors are the folks who want us in their, that we have to get into their house, so to speak, as I said before. In order to do that, there's definitely not an alignment necessarily from the pharmaceutical companies and the providers, especially in today's new healthcare environment, where really everyone's looking at cost savings and not necessarily prescribing the branded medication. So we looked at long term as opposed to short term, and I'm sure we walked away from a lot of short term money. I'm 100% sure of that, more than you know. But I think in the long term, we'll be a much stronger and more rooted company with the right alignments. So it took a long time. It was not easy, but I'm very happy that we made that pivot. And the technology side, it actually it was a little bit. It's different because now we have an integration piece with the electronic medical record and practice management side. We really didn't have to have a full integration before, although the more integrated you can be, the better. It wasn't a core aspect of what we're doing, but it was definitely a piece. So anyhow, there's just it's kind of just a different entry into the market and a different deliverable, but both of them are problems, and both of them involved access and communication with patients.
I think I'm going to chime in just for one question, because I think, Joe, you made a really good point, which was we chose a business model for the long term, even though there was some short-term opportunity and profitability. And most of these folks, I think, except CityMD, I think is self-funded, have raised outside capital. So I guess my question is, how do you pick the best business model to appease your investors today? How do you plan for the future? And we talked about these stakeholders. The world is still evolving. Adam talked about new stakeholders he needs to worry about. So maybe it's, to put a bow on the question, how do you choose your model, even though it's for the short term, and how do your investors feed into that?
If you don't mind, I'm going to take that first part because I'm going to be short though, and it actually was really important, and it's a kind of dovetailing on the response to your question. I think that's Anna, right? Yeah. So actually, a lot of our decision process was made by talking to investors, as well as clients, but actually a lot of pitches to investors. And I heard it before I went in, and I'm a firm believer that the investors are actually extremely valuable because they have a lot of input and they have a lot of they're looking at you from an outside perspective, and I got pretty significant feedback on the business model, and I think helped us to redirect. So it was hard to hear them say no, but after they said no, and this is in the beginning, we did raise money since then, but after they said no, most of them took the time to give us some ideas and some inputs, and we listened, to be quite honest with you. But it did take a long time, and we did a lot of pitches early on. But it kind of became one of those things, okay, I've heard that enough times, maybe they're right, and also there's other reasons. But the investors were extremely valuable to us from a sounding board perspective.
Michelle, maybe you can ask the audience for some input.
I have a question.
Okay, hold on.
We announce our names?
Yeah, sure.
My name is Amir Asadi. You and I think we're thinking along the same path. The business that each one of you does, the profit margin and the revenues that you receive, are these all for each one of you? Is it fee-based that you could stand alone on your own? Or is it a savings or a sliver of that savings that you're bringing to the consumer of your product, and you're participating and sharing in that savings that they're getting? So really you're becoming a cost-neutral entity to them. But could you stand alone on your own if you had to charge for the fees that you need to sustain yourself and pay enough to your investors.
It's AJ again.
No, this is pretty easy for us. So B2B software, revenue is king. You need to be able to stand alone because you have to be performing a service besides savings, because you have to be solving a problem, not just identifying the problem. So over a long enough period of time, your error rate or defects should be going to zero. So here's a great example. Like, we could work with a client and we'll find a 15% error rate, which is worth 3% of their drug spend. Great. But once we take over, that should go to 10 basis points, 7 basis points. You know, there are defects in the system because there are still paper claims to this day. So there's always going to be some error rate, but you're entering the realm of, you know, multi-million transactions and small error rates. That's what you're trying to go for. So you have to stand on your own. From our point of view, like our validation platform, we need to continue to monitor the process, but we hope it's good news. It's zero, or it's a few basis points of error. You know, on procurement side, there's always some form of savings there, but our value is the fact that no one understands pharmacy benefit transactions. And I could say that with confidence. And then the last part of it is on the reporting platform we provide. You know, some of it's savings in man hours or automation, but most of our partners are fairly sophisticated. So we just have a better narrative, or we have a better format, or we have a better way of helping their partners or underlying payers understand these benefits. So I think it's critical. You have to stand on your own, because if you sell on savings, either you're part of the problem and you're never solving it, or you solved yourself right out of a job.
So we're primarily fee-based, but I like to talk a little bit about this kind of value in terms of cost reductions, because, you know, our families pay us directly, but now in this new healthcare environment, we're working more and more with managed care companies, particularly with dual eligible. So when you're going to talk to payers about how you're going to save them money if they only pay for your service, basically what you're saying is, you know, I'm going to give you you're going to give up one bird in the hand for two in the bush, right? You're going to give up money right now that you're paying for the promise that we will have cost savings later on. So that is a long sales cycle, and you better be ironclad tight on your outcomes.
As a payer, I would say absolutely.
Yeah, we have a question back here.
Hi, this is a question for Joe Blewett. When EMRs first became, it's a couple of statements and a question. When EMRs first became sort of a reality, I always wondered why there wasn't more of a push by pharmaceutical companies to basically underwrite the establishment of registries in disease categories that they were interested in. I'm wondering if you've thought about that, about tying into that and sort of initiating that effort, because, you know, in terms of B2C, pharmaceutical ads to consumers, I'm wondering how viable a method that is. And I don't completely know what your business model is yet. I'll talk to you later. But I wonder if you've thought about that and what your thoughts are.
So to be quite frank with you, I think in this forum, I'm not necessarily going to answer that question directly. And don't take that personally. But what I will tell you is that what we're not interested in is marketing for pharmaceutical companies or other advertisers. What we are very interested in, and we are definitely strategically poised to do, is to help with strategic initiatives around better health outcomes at lower costs and better overall health environment for patient populations. So if it's going to fit into that mode, and it's if there's multiple alignments, then we're going to be on board with it. And we have strategic plans for those types of offerings. And what you described is very much in line with what would be part of our long-term strategic business model.
Hi, my question is for Michelle. May I ask you a question?
Sure.
I'd like to know from the payer perspective, how do you feel about high deductible wraparound policies and how they relate to direct primary care?
Okay, well, I'll give my, just say a bit more about what you mean by high deductible wraparound policies.
So Cigna and a couple other payers have started embarking on these kind of partnerships with the employers and direct primary care clinics where they'll offer a high deductible catastrophic plan for the employees, and to complement that, the employee will have access to a direct primary care clinic.
So you're talking about on-site clinics at a company, you're talking about Iora Health type models
Exactly,
where you
like
pay...
Iora,
Like
yeah.
Iora Health type models? Okay, so I just want to caveat, like my opinion is my personal opinion. I'm not representing any payer in this regard. So look, I think it's challenging. I think the world really is shifting to high deductible plans, and a good analog is looking at how we've shifted from defined benefit to defined contribution. So if you can imagine, you used to retire and get promised a certain amount of money every year. That is not the case anymore. Maybe you're promised a 5% match on a 401k plan, and you have to manage it all. And so if we are shifting risk onto consumers, then how are we supporting individuals to access care, to become educated? I have a personal close friend at Iora Health, and I think the model is really interesting. I think, Calvin is talking about access. He's trying to get people out of bed when they're sick. Having access to primary care that you have a relationship with that physician, that you feel comfortable communicating with them in a technological manner, I think it's a really good thing. I think people want to feel healthy and be well. And we should be focused on engaging and have access to our providers, not when we have a problem, but maybe when we just have a question. So I don't know from a cost perspective how it all ekes out, but I think as one of the capabilities to complement or to wrap around a high deductible plan, some sort of direct primary care and enhanced primary care is a good thing, especially if it has the potential to reduce specialty visits. If it has the potential to reduce, going to a CityMD when you're already sick or going to an ER. If you look at sort of Oscar Insurance here in New York, one of their taglines is, teledoc on demand, don't worry, you can call a doctor anytime. I think people believe, and I believe, we just want to be healthy, so just let us access what we need when we need it. We won't come running to you when it's too late.
Here.
Could each of you describe a business model that you were confident would work, realized it doesn't work, how you realized that, and how you refined it or changed it? So basically something that, dead ends, and your realization of that and how you confronted that.
Whose turn is it? Okay, Adam.
Well, I would say kind of... I would say kind of in our in our pivot in terms of our model that we had we were having success, but that we wanted the success to come more quickly, and that also we were seeing the changes kind of in the healthcare landscape, and that we had to adjust to them. So for us, within long-term care, generally individual facilities are completely self-sufficient in the sense that marketing, sales, operations, all of that is done through one facility. Now, we keep our centers very small, and we do that we cap our enrollment per facility at 60 people per day, and we do that because it really increases the quality of care, kind of like when Michelle was talking about in terms of a relationship. If it's kind of like the Facebook problem, like how many people can you really know and be friends with? We feel the same way about our nurses and our aides within our facilities. How many people can they really know and understand? Within such a small facility, all these different areas of operation was too difficult for the amount of management staff we could have at that size and that revenue stream per location. So we moved to a new operational model of clustering, where basically an entire market of locations would be run by a specialized sales, marketing staff, and operational staff. So there was like a back-end component of that business model pivot. Now, what that also did for us is because we had that specialized staff, it opened up this complete kind of front-end consumer ability to offer a whole host of specialized services cost efficiently, because that specialized staff was not being they need to spend all their time on the day-to-day management of the operations. So that was kind of our pivot, and it was both a back-end issue of operations and a front-end issue consumer-facing of how can we provide the services that people really want in a way that doesn't break the bank for us.
Real quick, I mentioned earlier that we went through kind of a product pivot, so I'll give you a marketing pivot. I mentioned earlier that you naturally may attract enemies, and you didn't realize it was your intention to do that, obviously. An example that we had is consulting companies and brokers are some of our biggest clients today, B2B. They service their clients. So they have a who's who list of unions and large self-insured Fortune 500 companies, Fortune 1000 companies. And early on, we had to go to some of these clients directly to kind of prove our business model, prove our capabilities. And the brokers were angry. They're like, why are you calling Morgan Stanley? Like, why do you talk to AXA Equitable? Why would you do that with UBS? And I'm like, well, they wanted my service. And the light bulb goes off, and I'm just like, we would like or prefer to be the software solution for all of these broker and consulting companies. So we made a decision last year that we will never go direct again. I mean, it's bold. Someone knocks on my door and says, hey, I'd like to use your software. I would be like, you need to go through one of my valued channel partners. And what that did overnight is it was a treaty. There was an accord suddenly where we had made peace with the brokers and the consultants, and they're like, those guys are okay. They're not stealing my business. In fact, I provided them business, and I provided them a capability that they didn't have. So sometimes it's not just product, sometimes it's marketing.
So CityMD, we are very confident today about our business model, that it is very sustainable, but we are planning for the future, and in the future, we believe that we have to play nice with everyone else in the room in healthcare, payers, government, and other providers as well. So we are using data, big data, and all this to coordinate care for the better, so that, I think over a long run, the cost of providing healthcare is going to decrease. So we want to be, we're actually changing a lot of our business model to go into a more efficient, and what it means, I guess, is cheaper is not really the right word. High quality care, but a lower cost value, good value for the money that you're paying.
So I kind of answered the question a little bit before, so I'm going to be really quick. And I'm going to turn the question around. You asked, how do you know when you get to a point where it's not the right business model? I think maybe another way to look at it is, how do you know it is the right business model? And I think the key there is to find somebody who actually is willing to write a check for your product or service. And if you're finding people that aren't willing to write a check, or if you have an app or something, that, a service or whatever, and you're having to do free pilots and give it away, and then I think you probably should really look at what you're doing, especially if it's a developed product. So really look to find out if somebody's willing to pay. If they're not willing to pay, then be really careful about what your business model. Maybe take another look at it or the product. And then the secondary thing is, in addition to my investors, we went through an accelerator program last year called HealthBox, and I'm glad to plug them, but that's not my point. They were awesome. But my point is that the accelerator and the incubators are really, really helpful in helping you define business models and measure them.
Okay, we have a question from the audience.
Time to go. I was just going to say, Calvin, with such a consumer-facing brand that relies on the promise that you're going to provide great service, what's your contingency plan if you have a Jack-in-the-Box moment or something where a customer really goes through a negative experience that can destroy the brand overnight? How do you mitigate that risk, and what are you and especially going to have in place when something like that potentially happens?
Great question. I think we're aware of a lot of the dangers that exist with the brand. It is a very kind of retail, consumer-facing brand today, and I think we do what we do well, which is providing access. I think the bigger problem is potentially, our biggest complaint is really the bill that they get after they come visit us, although it's EOBs, and that's where they get the shock, and that's where they say, this is a problem with healthcare because I spent 45 minutes here and my bill is this much. It shouldn't be. So I think we're trying to solve a problem along with all the constituents in the healthcare world to change healthcare, and that's what we're part of a movement to make it more value-based, more cost-efficient.
Just to build on Joe's point, which is about how do you know if the pivot's the right pivot, is when the cost of acquisition goes down. If you're pouring more and more money into marketing and sales to get that sale, then it's the wrong move. And if it's going down, then it's the right move.
So I think we're out of time, but I actually want to that was a really good point. It may even be better than my wrap-up point, but that's okay. So before I don't want to stand in the way between, you and drinks and food, but, and before thanking the panelists, I just wanted to make sort of one point, tease out one insight from the whole conversation that we had, which is, I believe that at the end of the day, when you're solving businesses or when you're building businesses, it's about solving problems for people. That's it. You're solving problems for people. And when we talk about business models and business model pivots, each of these entrepreneurs may have decided, in Joe's case, to solve a different problem for a different stakeholder group. Or in Calvin's case, in Calvin's state, to realize he's solving a problem for the patient, but he needs to be mindful of all the other stakeholders in the marketplace who have an interest in what he's doing. So he needs to, quote unquote, play nice. In AJ's case, he first started out solving a problem, but his stakeholders weren't ready to have that problem solved. Now, it's not to say that product is not going to be back in the market, but timing also matters. So he's still solving the same world of problem, but in a different way. And then with Adam, I think, probably had the cleanest sort of model to begin with. He knew he was solving a long-term care problem, but it sounds like his biggest concern is understanding how his solution fits in the managed care space with providers and now building more of a network. So I guess the punchline is if I was giving any advice to entrepreneurs, and having gone through it myself at Aetna, is focus on the problem, really understand the stakeholders. Don't think the stakeholders are going to stay the same. They're going to change, and be willing to follow and track the value that you're contributing, because you may find you have new stakeholders that you can provide value to. So that's sort of my closing thoughts, and I just want to thank sort of Meryl, and I'll turn it back over to her, but I want to thank the panelists and the audience, and hopefully this was somewhat informative.
Okay. I'd like to thank Michelle and our panel, Joe, Calvin, AJ, Adam. You've been a great group to work with. You're all bringing a different perspective to the issues. I thank the audience for their questions also. I hope we've stimulated a lot of thoughtful conversation. And of course.
And smart design.
Thank
Smart
you.
design.
It takes a village. So I thank you all for coming out, and you probably all missed the storm outside. You are all better off in here as we get ready for the holiday. This was the place to be. So we have the room for another half hour. We invite you to continue networking, have some food, have a drink. And for those of you who would like to continue the conversation after, we thought we'd take the after party over to a place called Half King. It's a great little place over at 23rd Street and 10th Avenue, and we'll be heading over later and give these folks a chance to wrap up the place. So thank you very much, and we look forward to seeing you at our next event. Have a good summer.